Minnesota is making a generational investment in mental health care. New money approved by the legislature this year is aimed at a major renovation at the Anoka Metro Regional Treatment Center, and we'll hear what that means for Minnesotans. This is Hospital Matters, a podcast from the Minnesota Hospital Association. We're having conversations about issues impacting hospitals, health systems, and patient care in Minnesota. I'm your host, Tim Nelson, and I'm joined in this episode by Sue Abderholden, Executive Director of the National Alliance on Mental Illness Minnesota, also known as NAMI Minnesota. We talked about the historic and long-needed upgrade the legislature approved to address the most acute mental health needs in the state.
So what the legislature did is provide money, $75 million. $55 million was in the bonding bill. The rest was in the Health and Human Services finance bill. And it's actually to eliminate the current Miller building, so kind of destroy that, and then add an additional 50 beds for people who basically are coming from jail, who have been deemed incompetent to stand trial and court-ordered to treatment, and about 10 people who are coming from community hospitals who will also be added to the wait list.
So I keep hearing about the Miller building. Tell me a little bit about that facility and its role at the Anoka Metro Regional Treatment Center. Tell me, a lot of people might not be familiar with that.
It's a very, very old building. At first they thought, well, maybe we can remodel it. We actually visited it with Senator Abler, looked at it, and there's no way that it could be remodeled to actually fit today's safety criteria. You want to make sure that the ceilings are high. There's all sorts of things like that. So right now there's a small substance use disorder treatment program in it, which will obviously have to be moved as they destroy the current Miller building.
So these beds are going to be in addition to the capacity at the Regional Treatment Center now?
That's correct. So there's about 100 beds right now at, we kind of refer to it as AMRTC, and this will be an additional 50 beds.
So you said some of these folks might be coming from jails, from other facilities. What kind of care is this new facility going to offer?
So it'll offer hospital level of care like it does at AMRTC, and again, to try to restore people to competency in terms of their medical needs and mental health needs, not necessarily in terms of their knowledge of the court system.
So there's been a lot of attention to the 48-hour rule about getting people out of jails and into some kind of care, people being left in jails for weeks or months at a time. Tell me a little bit about how this is going to address that problem.
So first of all, when the law was first put into place, around a decade ago, we saw about 47 people who were deemed incompetent to stand trial and who were committed to a state facility. That number now is over 400. And so we have really seen an enormous increase in the number of people deemed incompetent to stand trial and committed. And it's not just happening in Minnesota, that's actually happening across the country. I even served on a national task force looking at this very issue. So when the 48-hour law first went into place, it was like, okay, we can deal with these 40-some people. There's no way that they can deal with now 400-some people. And so there's been a couple of things. One is there was actually a competency attainment task force. It was a bill that we worked on to create the task force, and they came in with recommendations, many of which passed about 2 years ago. The new system has been in place a year and has shown great promise, and it really is to make sure that people who have a misdemeanor, for example, where often the charges are dropped, that they don't just get turned back into the community without any community support. So now we will have forensic navigators who will look at the person holistically. Do they have housing? Do they have insurance? Do they have a mental health provider? To really stop that kind of revolving door into the jail. And we're hoping that helps. The second thing that happened is the legislature created a task force to look at the 48-hour rule. I would say that a lot of us think that it's a law that doesn't work anymore. If you cannot meet it, and we won't for years to come, then why have it, right? And what it does is it sets us up for lawsuits. And that is not what I want to spend any money or time on. And a lot of other states have actually been fined hundreds of millions of dollars, and that's not what we wanted to see in Minnesota. And so we've looked at this for, a couple of different ways. So with people who really need that hospital level of care, we just looked at it and said, we do need to add beds. And I will say we are always hesitant to add state hospital beds because people are traveling far from home. And it's, again, it's not necessarily community-based, but we really looked at the numbers and everyone kind of agreed, let's go for 50 beds. And that will help kind of relieve the pressure. Now, of course, it's going to take a couple of years to build that hospital, but it will relieve the pressure that way. But there were other things that we also looked at. So when we think about who gets into the jail and the number of people are there, we need to think about, well, who brought them there and how could we have prevented that in the first place? And that is problematic. We are not going to, build our way out of this problem. We need to think about how to prevent people from getting there in the first place. And so there were a couple of things. One is we have mobile mental health crisis teams across the state of Minnesota, and those are very important. We now have 988, another resource, so that we're having a mental health response to a mental health crisis, not a police response. The other thing that happened this session is there is a type of transport called protected transport, and it's funded under non-emergency medical transportation. And when we conceived of this quite a few years ago, it was as an alternative to police taking someone, for example, to the hospital. Well, we have hardly any vehicles. And the crisis teams were given kind of one-time money, which is hard then to increase your team because it's one-time money. So we are now allowing them to actually use that money to purchase a protected transport vehicle so that when a crisis team goes out, they don't actually have to call the police at all. They can actually transport the person to the hospital. And that's important because what we're seeing more and more, frankly, since George Floyd's murder, is that when the legislature changed the deadly use of force law, we saw a lot of police officers across the state of Minnesota say if that person who's in crisis and they've been, the crisis team has said we're going to do a transport hold, they're going to meet the criteria. If that person won't get into the car voluntarily, the police won't take them. And then we're afraid that what happens later, and there's no way to prove this, right? But that the person gets sicker and sicker and sicker and then maybe hits a family member. Now it becomes a domestic issue and then they're brought to jail. So we wanted to try to figure out how do we just prevent people from going into jail in the first place. And then we wanted to look at are there other alternatives. So we were able to pass legislation to create what we call locked IRTS facilities. And IRTS stands for Intensive Residential Treatment Services. 16-bed facility so that they can get Medicaid, because anything over 16 you can't if it's solely for people with mental illnesses. But they're locked, which we think a judge is not going to let someone that they're afraid of elopement or something like that just go to any IRTS facility. So that did pass. We figured out the problems with the Medicaid, the CMS, Center for Medicaid and Medicare Services. And so we're hoping that in the future that we'll see some of those built, which will also help relieve the pressure. The other thing they did is included funding so that we can kind of increase the capacity of jails to actually provide better medication and services to people. What people often forget is like, oh, that's a person with mental illness. They're in the jail. They're going to go to the state, facility. They're often in the jail for months before they're court ordered to treatment. So what are we doing during those 3 to 4 to 6 months to make sure that they're not decompensating, that they're not getting sicker, right? What are we doing? And so this was a step to say, let's provide some medications. Let's provide some, kind of training to do frankly, injectable medications, which are easier than trying to get someone to take medication every day. And again, really work on resolving some of the mental health crises that people are experiencing in jail. So that was another thing that we looked at to try to, again, address this, because we can add beds, but it's not going to solve the problem.
A lot of people may be aware that, the problem is much bigger. People are spending weeks, days in the hospital or in the jail. How does addressing these most acute cases trickle down into the rest of the system, into the rest of the population?
What we've seen in community hospitals is who have been great at actually addressing, our community mental health needs. But once in a while, you get someone whose symptoms are really, really quite severe and might be aggressive. And so what community hospitals have to do is to take beds offline in order to keep people safe. And when you take beds offline, that means more people are going to be waiting in an emergency room for a bed. And so it was important, 2 years ago and again this year, to at least add that 10 people from a community hospital based on, priority admissions, based on, kind of clinical needs, could be moved to, for example, Anoka. and then free up those beds at that community hospital.
And they extended that this
And they
year
extended
as well.
it for 2 years, yes. Yep. And NAMI was totally behind that because we've seen that. And, again, I know community hospitals have worked very hard to, address the needs. And we are different than some other states where even acute care is provided by the state, not by community hospitals. And we believe, frankly, that it is important. Actually, President Eisenhower, in his big report about how we should build a mental health system, said every community hospital should have psychiatric beds so that people are treated close to home. And we really believe that in Minnesota.
As you describe this, hundreds of people who are in jail, on hold orders that don't have anywhere to go. It feels like this is just a drop in the bucket. I can't imagine that this is a long-term solution.
I actually think it is, because remember, you're not just serving 50 people a year. They don't stay in there for a year. And so there is turnover. Think about it as a front door and back door issue, right? And so first, we want to prevent people from needing that level of care. So let's treat people in the jails appropriately with the right medication. Let's make sure people never get into the jail in the first place. But then we look at what's happening at the back door at our state-operated facilities. So if there are no community programs for them to go into, they're staying there longer. And so, you can't just build up that kind of front door, so to speak. We got to make sure that we have a way to get people out when they no longer need that level of care. And that happens quite a bit, actually. And so we also need to be looking at how do we build up the community mental health system, again, so that we have a wide array of services and people are moving through the level of care that they need, and they're not stuck in a level where they shouldn't be, and especially the highest cost level of care.
And you've talked about this community care. You've talked about IRTs. I know that Medicaid has to be on your mind here as you watch what's happening in Washington. What do you think of the situation right now?
I almost have no words, to be honest. I'm horrified about what they are even suggesting. Medicaid is the largest payer of mental health services because, honestly, mental health parity is still a dream and not a reality. And so many people with mental illnesses rely on Medicaid. And so many young people with mental illnesses rely on Medicaid expansion. And so we're just so worried. I mean, if you think about it, before we had Medicaid expansion, under the Affordable Care Act, basically you could have a 23-year-old with schizophrenia who basically has to go to the Social Security Administration and say, I will never work again. I will never have gainful employment again in order to get the health insurance that they need in order to get better. And that was, frankly, horrible. We should never have anyone having to say, I can't work again in order to get the health insurance that they need. And so Medicaid expansion allowed these young people in particular to get access to the care that they need without ever going to Social Security, and they get the care that they need, and then they can actually go back to work or back to school. And so Medicaid expansion is so important. And then, when we look at the federal level, it's like, well, we might change the percentage that the federal government pays for that. We might add work requirements. And people are like, oh, work requirements, that makes sense. Except that they say, it will only be for able-bodied. What does able-bodied mean? It's not going to mean, it's going to mean actually these young people who are not certified as disabled. It's going to include them. Well, what if they're in a treatment program? What if they can't work? What if right now they are, really focusing on getting better, and now they can't put in the 80 hours a month or figure out the paperwork to do that, and then they're going to lose their health insurance. And, we're worried about people in the jails now. Just wait. If we look at what might happen on the federal level and impacting Medicaid in our state, we will see more people end up in jail. We will see more people be unwell. We might see, a rise in suicides. We will certainly see devastation
more
to
people
many
in
families.
hospitals.
Absolutely. In the emergency rooms, instead of getting care earlier.
Well, I hope it comes to a happier end than that.
I hope so, but I really hope that people speak out against this. We've seen, a lot of people, rise up, frankly, across the country saying, no, we support Medicaid. We think it's really important. And I just hope people keep sharing their voice on this one.
Well, thanks for sharing your voice.
Thanks.
Again, that's Sue Abderholden, Executive Director at NAMI, Minnesota. I'm Tim Nelson, and you've been listening to Hospital Matters from the Minnesota Hospital Association. Join us next time for another look at issues impacting hospitals, health systems, and patient care in Minnesota. Thanks for listening.